Okay, moving on to deep fascial suture pain. This and constipation are probably the most common reasons why patients will call you as the PA and have a complaint of, I can't go to the bathroom, I've tried everything, and my abdomen really hurts. So you kind of have to determine what's going on there. Um, Abdominal pain only with movement near the surgical incisions. Their pain is worse with bending over or laying on their side. It's relieved with rest. Those are the key things. It's usually secondary to their deep fascial sutures. And this can be, if it's laparoscopic, it's at the trocar sites. We do these deep, big bite sutures trying to close that trocar port site because we do not want a hernia going through there. So when you take those big bites with your sutures and stuff and pull really, really tight, it's like a tight purse string, and until those dissolve, or, it takes a while to dissolve, it can be about 3 to 4 months, they're going to feel this pain and they're going to be calling you a lot about it. So you just kind of have to continually reassure them that this is okay. You may even feel a pop at the 3-4 month mark. Nothing, you didn't damage anything. It's just the sutures, dissolving and, popping apart. And that's fine. That's okay, because all the surrounding tissue has already healed. It's fine. Some of the bad things, though, you need to make sure that you rule out before you say it's just due to deep fascial suture pain are hematomas, seromas, surgical site infections, some deep space abscess, things like that. So some of the times the patient will present with fever. They have this persistent pain that just won't go away. It's not relieved with rest. It's constant, not just with movement. They have drainage, doesn't matter what color. Erythema, redness around the surgical site, abnormal induration or fluctuance, and tenderness to palpation just with light touch, not with deep, but just very light touch. The patient can be in a lot of pain with these things. So you want to rule those out. If you've ruled out that that's not the case, it's a non-emergent acute issue and you don't have to go back in and open them up and drain these things, then you just advise your patient, no heavy lifting, continue to walk around the house in small spurts 8 to 10 times a day because you don't want to get into DVT, right? The deep fascial suture pains, again, will dissolve in about approximately 3 to 4 months. And once the skin edges have healed completely, then you can kind of massage the site to break up that buildup of scar tissue. Because some patients, of course, that's one of their concerns about the way their surgical site looks, their surgical incision and scar. So this is something that I was asked to talk about. They've added a few things on here, and it's great. So this is something you always need to keep in the back of your mind when you have a surgical patient post-op who is presenting with fever. So we're going to go through these, some more in depth than others, but we have waves, these are the 8 W's. We have waves for myocardial infarction, wind, atelectasis or pneumonia, water for UTI, wound infection, walking, DVT, thrombophlebitis, wonder drugs, so drug fever is another name for it, withdrawal, like alcohol consumption, things like that, and wonky glands, so that's adrenal insufficiency and thyrotoxicosis. So let's hop in here. So we will start with post-op fever case. This is from the JAPA journal that I got. It's an awesome article. I recommend you read it. I think Joy will have you read this as well, but I literally pulled all the important stuff out of it and popped it onto these slides for you. So when I cited it down here, just so you guys have it as well. So here's a case that we can go over, and then at the end, after we talk about these 8 W's, we'll go through what we think this patient has, one of the 8 W's, and what we should do at that point. So you receive a call from the nurse regarding a 47-year-old man who had an uncomplicated laparoscopic sigmoid colectomy 2 days ago for a nearly obstructing but benign polyp. The patient just spiked a fever of 102.4 degrees Fahrenheit. On your initial evaluation, he is tachycardic with a heart rate of 109 beats per minute and a BP of 143/87. His O2 sat is 94% on room air, and his respirations are 18 and unlabored. Okay. So post-op fever, an adult is defined as greater than 100.4. So that's something you need to look at. Usually the most non-infectious causes are during the first 48 hours. After this time frame, it's usually secondary to an infection, so keep that in mind. And you need to remember that with immunocompromised or elderly patients, they may have a blended fever response to infections. So these are patients who are post-transplant drugs, they're on chemo, they've had chemo, they're on biologics, like medications for Crohn's, psoriasis, rheumatoid arthritis, things like that, or they're taking glucocorticoids. So they definitely could have a blended fever response. So keep that in the back of your mind. Fever, though, post-op fever can be a normal physiological response to surgery, as any surgery causes cellular injury and an inflammatory response, and cytokines are released during this and ultimately raise the patient's thermoregulatory set point. So it can be a natural thing. It may not be caused by anything else other than this patient just went through a major surgery, okay? I put these in here for you. You can refer to them. I'm going to go through each W for you, and we'll talk about, when they happen and how the patient presents, and you can come back to this slide and look at your clinical approach to the patient, okay? So waves, MI, it's the most common complication post-op day 0, meaning perioperative, day you did surgery, okay? Per up to date, and I put this in quotes, a patient age 45 years or older undergoing in-hospital non-cardiac surgery, complications of cardiac death, non-fatal myocardial infarction, heart failure, or ventricular tachycardia occur in up to 5% of patients. Of these, perioperative myocardial infarction, MI, is the most common. That's 5%. So we need to definitely be on the lookout for this, okay? For wind, atelectasis. So we all know atelectasis is like a collapse of the alveoli, secondary pore inspiration post-op. It's most commonly looked at as the reason for early fever in a post-op patient. However, there's no really good evidence, persuasive evidence now, to support a causal association between atelectasis and fever, or the severity of atelectasis and fever. So why does this happen, though? It's in the first 48 hours, usually right in the immediate post-operative period. Why? Post-op patients spend most of their time lying around, sitting in bed. It contributes to poor, incomplete, lung expansion. They take small, shallow breaths, and they don't get a good lung expansion. So they can have atelectasis. So we treat and prevent atelectasis before it turns into pneumonia. One of the prevention things that we do in surgery after post-op is we order and put the patient on lung expansion pathway. That's an order we have. And that's incentive spirometry. So incentive spirometry is a device that helps post-op or hospitalized patients, not just surgical patients, take slow, deep breaths. They are able to expand their lungs to assist in the prevention of atelectasis and pneumonia because the patients just take these poor, shallow breaths afterwards, probably secondary to pain. They're sitting there. They're on narcotics too. It just all adds up to that. So, atelectasis can be a pretty common thing after, your post-op patient within the first 48 hours. So pneumonia, hospital-acquired pneumonia, greater than 48 hours it occurs. Again, it's secondary to length of ventilation, aspiration, and just poor lung expansion. Patient will usually present with a fever. They'll have shortness of breath. They can be tachycardic. They can be tachypnic. Hypoxic, they can have a cough, decreased breath sounds when you listen, crackles. Chest x-ray will show some infiltrates. So water, this is usually UTI for water. Most common fever source, 48 hours to 5 days. Usually this is secondary to the urinary catheter, and the most common pathogen is E. coli. So if you're not doing a very sterile technique when you're placing this urinary catheter, you could have this problem, and you definitely do not want to have this in your patients. So the patients usually will have to go on not your regular prescription for a UTI. Now it's a hospital-acquired UTI, so it'll be a lot different. And UTIs in general make up about 40% of hospital-acquired infections. That's pretty big. So risk factors, patient has a prior history of UTIs, the length of catheterization has been there for a long time. Again, unsterile placement technique, if they're a female, of course, and if they're immunocompromised, like a history of diabetes. So water, what will the patient present with? Let's see here. For a UTI, again, fever, urinary frequency, suprapubic pain, flank pain, CVA tenderness. They could have an elevated white blood cell count. We'll go over wound here. So wound infection, most common fever source after 5 days, so greater than 72 hours. The most common pathogen here is skin flora. So strep, staph, enterococcus. Risk factors, level of contamination of the wound. If it's a prolonged operation, if they are a smoker, if they're malnourished, they're obese, geriatric, if you have a hematoma or seroma formation within the surgical site, taking immunosuppressive medications like what we talked about, if they have a chronic disease such as diabetes, COPD, renal, or liver failure, those are all risk factors for a patient developing a wound infection after 5 days or greater than 72 hours. So patients sometimes need antimicrobial prophylaxis if they have a history of past infections or MRSA or recent hospitalizations within the past year. They could be a carrier of certain bacteria like MRSA. So wound, we have different classifications. So first one, superficial, involving only sub-Q tissue, deep, involving fascia and muscle, and deep space organs. So that's kind of self-explanatory. So these are all surgical site infection classifications for you. So what would your patient present with? How would they be, if you would suspect a wound infection here? So they could have fever, again, redness around the surgical site, warmth, so it's warm to touch, purulent drainage, can smell really bad, very tender, just with that light touch like we talked about. They could have leukocytosis. They could be hemodynamically unstable. So when you have a patient that has a fever, leukocytosis, and hemodynamic instability, pain out of proportion to exam findings, you should be concerned about a serious illness, and they'll need a little bit larger of a workup. So this can include imaging studies to see if there's a deep space abscess formation infection, and this may require surgical intervention and antibiotics tailored to that pathogen once you've done your cultures. I threw this in here. You can look at this later. It's just nice to have. I found it on a website from a surgeon, post-operative care media file thing online. So surgical wound classifications, we have clean, contaminated, and dirty. And these are the common, definitions and some surgeries that usually use those terms. Some examples of types of procedures and the risk of infection with each. So when you're doing your surgical note right after you're done with the surgery and you're popping in there and doing a quick post-op note really fast, this is what you'll put in, what type of wound that you did during the surgery. Is it clean? Was it clean, contaminated, or dirty? Okay. Walking, one of the W's here, DVT usually occurs post-op day 3 to 5, greater than 72 hours. Also, you have to think about a PE as well. PEs, they are usually one of the causes for sudden death in the post-op surgical patient. So this is something that you definitely have to keep an eye out on. Bariatric surgery, we had a couple of these, so you have to definitely be aware. So post-op patients make up about 25% of hospital-acquired DVTs. That's a pretty large amount. So that's why we do our heparin. That's why we do our sequential compression devices during surgery. We get the patient up and ambulate them multiple times per day. We get them moving. And they also have those sequential compression devices when they go to recovery, and they have them when they're in their surgical bed, whatever floor that they're transferred to recover or be there for a few days before they go home, if that's the case. So risk factors for DVT, obesity, cancer patients, major trauma, ortho lower extremity surgeries, abdo and pelvic surgeries, the length of hospital stay, and again, insufficient ambulation post-op. Wonder drugs. Heparin and antimicrobials probably account for about a third of cases of drug-related fevers in hospitalized patients. So we've had a few of those where that happens, or the heparin causes some weird rash. Antibiotics cause a weird rash. So some of the medications, though, that present with fever of greater than 104, we'll go through these really quick. Anesthesia and malignant hypothermia. This occurs in the operating room, like actually in the operating room or later. So usually these patients are genetically susceptible to having issues with anesthesia, some reaction with it. It's caused by a calcium accumulation in regards to these medications that they're given. So signs and symptoms of this are fever, altered mental status, hyperthermia, and rigidity. And then serotonin syndrome. These are usually related to perioperative medications. They interact with the patient's SSRIs that they've been getting, and it causes overstimulation of the central and peripheral serotonin receptors. So the signs and symptoms of patients with this are fever, altered mental status, hyperreflexia, mydriasis, and myoclonus. So you're kind of seeing a little bit of a trend here with these. Then we have neuroleptic malignant syndrome. This is caused by dopamine receptor blockade and neuroleptic or antiemetic meds. So as signs and symptoms are fever, again, altered mental status, hyperthermia, and muscle rigidity. They're all kind of a little bit the same. So you gotta kind of look out for them and kind of deduce which one, could be causing the problem there. So in meds, those are the most common non-infectious cause of post-op fever. Withdraw. So sometimes your patients may not tell you or be quite honest that they've been drinking alcohol more heavily at home or prior. They have an issue. They may not think they do. They may be in a little bit denial. And this will definitely come about and come to a head if that's the case. So ETOH withdrawal secondary to abstinence can occur within 6 hours of cessation. So if your patient is definitely not eating, their NPO and everything right before the surgery, they could definitely go through withdrawal if they're hospitalized for 3 days. So they're more at risk for delirium tremens. So this occurs within 72 hours after last alcohol ingestion. So some of your signs and symptoms are they're sweating, they have a headache, they're not able to sleep, they're really anxious, they may have an altered mental status or hallucinating, may be very agitated, and then of course they could potentially have seizures. So we're trying to avoid that. So you want to make sure that you get a proper history from the patient. Really ask. Don't be afraid to ask. And this is, sometimes overlooked, as most, headaches, insomnia, sweating can just be a normal post-op complaint from patients. So you really have to, ask your patient about these things. Don't be afraid. Wonky glands. So probably less than 12 hours with wonky glands, you could get adrenal insufficiency. So those are at risk. Those are the ones who have been on corticosteroids prior to surgery. And these patients need kind of a stress dose adjustment. Though we usually do that if they've been on corticosteroids, if they're post-transplant or they're on them for other reasons. We talk to anesthesia, we talk to pharmacy, and we figure out, how much does this patient need to be on, during surgery or after surgery, so we can make sure that their body can adequately respond to the effects of surgery. So sometimes this adrenal insufficiency can also happen in a patient who's undiagnosed with it. So you may not even know it. So it's not just those who are on corticosteroids prior to surgery. They may not even know they have this problem, and it can occur. So they definitely have a difficult time adequately responding to the stress of surgery and subsequently fall into adrenal insufficiency. So signs and symptoms: fever, hypotension, hypoglycemia, hyponatremia, and hyperkalemia. Thyrotoxicosis can occur less than 48 hours. Those who are at risk are patients with unknown or known hyperthyroidism, or they did not take their meds because they were told not to eat anything, so they didn't take their meds. Increased risk for thyroid storm, some signs and symptoms, tachycardia, hypotension, hyperthermia, and altered mental status. And you definitely want to rule out those life-threatening causes. So I thought I'd throw these in here. These were also in that article. So neck fash, sepsis, PE, malignant hyperthermia, serotonin syndrome, neuroleptic malignant syndrome like we talked about, delirium tremens with seizures and ETOH withdrawal, adrenal insufficiency, thyroid storm, and gas gangrene, so myonecrosis. So let's go to our post-op fever case here. What's the cause? Let me get rid of that. So what's the cause, do you think? I'll read it again. You receive a call from the nurse regarding a 47-year-old man who had an uncomplicated laparoscopic sigmoid colectomy 2 days ago for a nearly obstructing but benign polyp. So this is just 2 days ago. It's uncomplicated. He's 47 years old, okay? The patient just spiked a fever of 102.4. So this 2 days post-op. On your initial evaluation, he is tachycardic with a heart rate of 109 beats per minute and a BP of 143/87. So not that bad, but he's tachy, he's febrile. His O2 sat is 94 in room air, a little low, and his respirations are 18 and unlabored. So, respirations are still in the range of high normal, but still a little high. So does this look infectious to you? Is it non-infectious? What do you think? So at this point, I doubt it's infectious. It's most likely due to atelectasis because it's post-op day 2. He's a little febrile, a little tacky, not too bad here. So he probably has atelectasis, and this is just a fever secondary to the physiological response from surgery. So your next steps will be to order a chest x-ray just to make sure he doesn't have pneumonia. Incentive spirometry, right? Get him on that lung expansion pathway. He should have already been on it if he's in hospital, but maybe he's just not being quite, diligent in doing his incentive spirometry while he's sitting in his bed. So you definitely want him to ambulate and do his incentive spirometry, and that will aid in lung recruitment for him. So we're towards the end here. So some pearls I put in here for you are, I learned from one of my plastic surgery preceptors that PA stands for prepared always, and I've always taken that to heart. I always want to be definitely prepared for my surgeon, my patients. I'm always trying to be one step ahead for them and know what's going on, have everything set up, and just definitely be prepared for anything that may come my way as a PA. So you want to try, this is something that really helped me, try and follow at least just one patient from start to finish. So if you're in the pre-op visit and they're going to have their surgery in a few days and you're able to go into pre-op and be with anesthesia, see your surgeon, talk to them right before surgery, do the surgery with them, go to recovery and follow up on rounds with them in the next couple of days after surgery. It's nice to see the full from start to finish and see how a patient is cared for and see their pathway through surgery and how they handle it. So another thing, know your anatomy. More specifically, know your vasculature and nerves. Again, I was pimped on this over and over and over. And I once was doing a colon resection with one of my general surgeons as a student. And we were in there and there was some dead bowel. And he asked me, why, where do you think there's, possibly, a clot or something that's blocking this? And I had to sit there in my mind and go, okay, I have to go back to the branches off the aorta and figure out, what goes to what part of the colon and mesenteries and everything. And you definitely need to know that. So bring your anatomy book, have that there right before the surgery and kind of know what's going on. Especially if there's possibly bleeders and your surgeon doesn't notice that maybe a vessel or a nerve might be in that vicinity. Usually they don't. Like they definitely know where things are, but sometimes something may happen and you're definitely their second pair of eyes and ears and brain and hands. So definitely try to anticipate your surgeon's next move. That's very important. Know where they're going to be. This is a learned thing for students and for PAs but you can definitely get to that point where you just know what they're going to do, and you're right there with them, and you're mirroring them the whole way. So another hint here is anytime your surgeon has sutures in hand, be at the ready with your scissors to cut above the knot, right? You always ask, do you want it above the knot? Do you want a tail or no tail? So tail or no tail means, do you want a little bit of, string above the knot? You want a lot, or do you not want it all? You want me to cut all the way down to the knot? So always have some scissors ready. You can ask the scrub tech for it and just be ready on hand to just, cut it quickly for them. So another thing, like I talked about, is make your glue, stereo strips, tape, dressing, bandage meticulously neat and clean when applied. And again, ultimately, this is because this will be how the patient judges your work and how well the procedure was done. It sounds ridiculous and nitpicky, but this is just how people are, how we naturally are. And, if it looks bad and sloppy, you're going to think that somebody didn't do a good job. So always keep everything nice, neat, and clean in perfect rows. Be meticulous. Be picky. Okay. Another thing, most common suture techniques are simple buried suture. I call them deep dermals, or running subcuticulars. So get very familiar with these. I didn't even know that prior to surgery, and when I got in there, I was learning them like crazy. So you definitely want to know these. Ask before touching instruments, sponges, sharps, or scrub tech trays. Otherwise, you will get bit, as we call it. You will get your head chewed off. So definitely ask. Be respectful. If you do get something from the scrub tech tray, like they give it to you, you ask for it, and before you put it back, you set it down and say, scissors back, needle back, Raytech back, lap back, so they know. And you don't say it too loudly, but you say it so they know it, and you set it down on their tray so they can count it and have that count in their head as they go. Another little tip here, write your OR cases down, because I think you have to keep a record of it. We did in Typhon when I was at Toro. Write your OR cases down that you do. You have to put the age of the patient, all their demographic things, and how long you were in there and what this procedure was. Write it down on your surgical gown transfer cards. So these little transfer cards are on your gown as you're putting on your gloves and putting on your gown. This card is attached to the little drawstring waist ties that you're going to grab and then hand to somebody and do a spin so they can tie you and they tear it off. But you can grab these and keep them and write them down. So then you can just put them in your pocket throughout the day, because it's hard to carry around a little notebook. It's hard to go back in and try and figure out who you did surgery on. You may lose track. So that's just a quick way to log them out later. There's this little paper card that's attached to your gown. So it's nice to just grab them and keep a quick little journal and then take them out at the end of the day and log them. Some books. These are the ones that I loved. When I was on rotations, my supervising preceptor was the chief of surgery. And my other one had been there for a long time. So I had two supervising docs there as preceptors. But the one chief of surgery said, you need the ABSITE review. So the ABSITE review is what surgeons use for their surgical boards. It's a great little book. It has tons of stuff in it. It's awesome. Great for when they pimp you. You already have it in your mind of, okay, this was, I can pick up this book and read it and know what I need to know in case they do ask me. Surgical Recall, awesome. That's a great book. You definitely need that. I don't know if they recommend it anymore, but I did, and my classmates did, and we loved it. It has the most common pimping questions when you're in the operating room, and then the Netter Atlas of Human Anatomy, or whichever one you want to use. But that, you definitely need to know your anatomy, hands down, in surgery. If you don't, you're going to be in trouble. So that's the end of the presentation. Thank you so much. Feel free to contact me if you want. My email's here. I'll answer your questions anytime you'd like. Feel free. I'm very open and receptive to questions or people wanting to know what surgery is about or like. But I hope that you enjoyed this presentation. It was a lot of fun putting it together, and I hope it gave you more of an insight into what it's like being a surgical PA. It's fun. It's very rewarding. It can be demanding. It can be tiring, standing for long periods of time. but it's so much fun being in there. It's just a whole new world, whole new culture, and it's just a lot of fun as a PA. So thank you very much.